Hello, good evening, everybody. Good evening. Thank you so much for being here tonight. My name is Kelly Johnson, and I'm the Chief Engagement Officer here at the Rothko Chapel, where we connect creativity, spirituality, and justice to build stronger communities in Houston and beyond. And welcome to our 31st annual MLK birthday observance, this year called We Got Us, Health and Care Beyond Capitalism. And we'll be discussing the evolving relationships between economic systems and policies, barriers to healthcare access and equity, and community-based solutions that provide resources for deeper collective well-being. Now, for those, I see a lot of friends and known faces, but for those new to the Rothko Chapel, we opened in 1971 as a sacred space featuring these monumental purple paintings that are surrounding us, which were created by Latvian-American artist Mark Rothko. This unique artwork, along with the architectural environment, inspires quiet reflection and contemplation. And as many of you may know, we're open Tuesday through Sunday for visitation, prayer, and meditation. In addition, the iconic sculpture on the plaza called the Broken Obelisk by Barnett Newman is dedicated to the legacy of Reverend Dr. Martin Luther King Jr. as a visual reminder of the collective work we need to continue together to create beloved community. Now, in 1979, the chapel started an annual MLK birthday observance to connect the contemporary implications of Dr. King's legacy to ongoing struggles for civil and human rights. And we've hosted many esteemed scholars, activists, artists, and faith leaders over the years to discuss pressing issues, including most recently in about the past 5 years. We talked about the epidemic of gun violence here in America. We talked about health impacts of US militarism, the media's influence on civil rights, and more issues that Dr. King wrote, spoke, and marched about during his short but impactful life. And now tonight, we continue discussions in our multi-year initiative on health justice, and we're honored to hear a keynote address from Houston-based physician and author, Dr. Ricardo Nuila, followed by an incredible panel of local health advocates, including tonight's moderator, if y'all can wave when I say your names, Josie Pickens with Up End Movement. Yeah, give her flowers. We've got panelist Krish Gundu of Texas Jail Project here with us tonight. And we've got Kay Matthews with the Shades of Blue Project. You'll hear more from each of them soon about their work, and you can also read their bios in the print program, which you should have had on your seat when you came in. I'd also like to thank our additional community partners tonight, who you may have seen and talked to upon entering, which include Texas Civil Rights Project, Prognosis, West Street Recovery and Northeast Action Collective, Houston Arms Embargo, and Food Not Bombs Houston. They will all be available to chat with you outside after the program on your way over to the book signing and reception, and they can share more specific campaigns and initiatives that you can get involved in to further health and care in our larger community. All right, so now before we hear from Dr. Nuila, please join me in sharing a warm welcome to Rothko Chapel President Imam Abdullah Antepli.
Good evening, everyone. What a delight, pleasure, and a distinct honor to welcome you all in remembrance, in honor, in celebration of Dr. Martin Luther King. I just celebrated my 4th-month anniversary in Houston as the president of This is an honor and privilege of a lifetime. I am loving to be the new historian and to be with you here to lift up the legacy of one of the greatest prophets of Martin Luther King. Today's event, in so many ways, will highlight to me the two main aspects, two main prisms of Dr. Martin Luther King Jr.'s legacy. In so many ways, Dr. Martin Luther King is one of the most beloved people in the United States. His name's in every road, parks, monuments, but his current popularity should not fool you. If you don't know already, during his lifetime, when he was murdered tragically, he was the least popular public person in the United States. His popularity was much less than current president, the previous president, or any other United States president. In so many circles, he was despised and hated. He made people uncomfortable because he was a prophetic person. In the tradition of prophets in Judaism, Christianity, Islam, Hinduism, and Buddhism, that's what prophets do. Their moral philosophies are not shaped by popularity. For those who lick their finger and feel the winds of the day, and that shape their moral philosophies, what is good and evil, based on what's popular, will never understand that aspect of prophecy. He made people uncomfortable. He didn't mind being unpopular. He morally critiqued the evils of his time and invited people to reveal the best of themselves in the most profound, effective way possible, so that many decades after his death, we are still celebrating. His prophetic voice, his moral critique is still reverberating. And here at Rothko Chapel, we are absolutely committed to that voice from Sinai, from heavens, that moral critique, to go loud and clear. Yet, what is even to me even more profound, despite being that moral prophet of his time and generations to come, somewhat paradoxically and counterintuitively, he was one of those very rare leaders. And the speakers that we have chosen today, in so many ways, through health justice, reflect on that mission of Martin Luther King. He would criticize, he will awaken moral responsibilities of American society in the context of civil rights movement on Sunday, and on Monday he's in the Oval Office discussing policy with President Johnson. He never burned the whole house. Moral critique was his starting point to get somewhere, to improve our moral fabric, moral health. It wasn't his ending point. He wasn't going to morally critique and end there. He wanted to improve. There is no one, please, I'm not a Martin Luther King Jr. scholar. I don't know of anybody that Dr. King didn't say, I will never talk to this person. I will never engage with this person. Or if I will only engage with if X, Y, and Z, A, B, C happens. He engaged, he built bridges. He never gave up on anyone. He called us to moral heights because he knew we could do better as a society. He knew that our foundational ideals propels us and forces us, compels us to do better. So in that spirit, as the president of this very sacred, iconic historical institution, I will try my very best to do my part to lift up these both main legacies of Dr. Luther King. Constant the critique, constantly invite us to do better ethically, morally as a society, but constantly engage, constantly try to build bridges between people of different disagreements, different persuasions, different backgrounds, so that it can only take all of us to do this job together. In this spirit, please join me in welcoming our wonderful speakers through the lenses of healthcare justice. Will lift up, honor, and celebrate Dr. King. Just a one word or a brief words about our keynote speaker, Dr. Ricardo. Over his decade-long career as a participating physician, intellectual, and scholar, Dr. Ricardo Nuila's first-hand experiences have fueled his writing on health disparities, healthcare policy, and the interface between art and medicine. His stunning debut, The People's Hospital, Hope and Peril in American Medicine, which details the stories of 5 Houstonians unable to access healthcare in his hometown of Houston, Texas, was selected as semifinalist for Carnegie Medal for Excellence in Nonfiction and named one of the best books of 2023 by Amazon, the Kirkus Review, and the Washington Post. Please join me in welcoming Dr. Nuila and all our speakers.
Thank you all for being patient while we got seated, figured that out. Thank you, Dr. Nuila, for your storytelling and all of the work that you do. I would love for us to begin, and we don't have a lot of time, so we're going to get moving, with talking about health as a human right and not a commodity. You described a system where access to care depends on money, insurance, paperwork, all the things. So I think we should start there and talk about what actually changes when healthcare is treated as a human right instead of something people have to earn or buy. And maybe we'll start with Krish. would you like to answer that question first?
I don't know this.
I think it should be.
It's on. Okay. I'm not sure I'm the right person to answer that question because the entire time Dr. Nuila was speaking about the People's Hospital, I could not stop thinking about the fact that this is the same system that provides health care in our county jail. But the standard of care looks extremely different from what we see in the community. You put the same system inside a cage, and it's stripped away of all its dignity and humanity and even the question of a human right. And I want to tell you a little story, because this has been on my mind today, because I just read the lawsuit complaint about this young man who died in our jail this past year. And I promised his mother that I would share his story every chance I got. So his name is Christopher McGregor. He was 39 years old. He played football for U of H. And in his second year of college, he started developing psychosis, severe schizophrenia. And what started was this decade-long cycling through emergency rooms and psych hospitals and the jail. He had probably been in jail about 12 times in 10 years. And then this last year, when he was finally arrested again on a criminal trespass charge, within a few weeks, he died. And when we finally got the records to see what had happened, it turned out that he had died of a strep throat infection. Who in today's day and age dies of strep throat infection? A person who is not able to advocate for himself, a person who has severe mental illness. Now, did the jail know him? Yes, he was in and out over and over again. Did Harris Health know him? The same system that provides healthcare in the community, that provides healthcare in the jail? Yes, they knew him. Did Harris Center know his condition? Yes, they did. That's the mental health provider for our community. They all knew him. They all knew what was going on. But no one's responsible or accountable, apparently, for his death. And his death was ruled natural. And so when I think about that, it's really hard for me to think about health or healthcare as a human right, because we had 153 deaths last year in our county jails. 20 of them were in our Harris County Jail. We've had deaths due to dehydration, starvation, water intoxication. These are the kind of deaths you would never see in the community. So the standard of care is so different. I can't even call it substandard, that it's really hard to even begin to answer that question. I'm sorry.
I think you answered that question beautifully through your storytelling, and thank you for sharing with us the differences that we see in the way that public health care is created in community versus in our jails. And conversations around human rights are a huge, huge part of that. Who do we think even in community and in the jails deserve these basic human rights?
Who deserves care, yes.
Yeah.
And if I could just quickly add one point to that, and I think it's really important for people to understand, that our county jail system in Texas is the largest warehouse of people with serious mental illness. Every time I say that, people sort of don't believe me. They think I'm making this up. But if you look at the data, the top 3 out of the top 5 psychiatric populations in the states are county jails. And Harris County Jail is the largest warehouse of people with serious mental illness and developmental disabilities. And every year, when we go to the budget meetings, the county budget and the city council, we give more and more money to law enforcement, but not to healthcare.
Yes.
We give more and more money to law enforcement and not to affordable housing or community-based mental health care, or economic opportunities or flood control, all the things that actually make us safe and healthy. So we essentially as a community have decided that we are going to keep investing in punitive solutions to public health issues. Because if your jail is the largest warehouse of people with serious mental illness, why are we investing in more law enforcement?
Yes.
That's the question that I think we have to engage with.
Thank you for that question. And I would love to hear from you, Kay, if you have something to add from your perspective and your work with Shades of Blue.
So I come at it in a little bit of a different way. I think by all means I am a storyteller because I believe that our lived experiences propel us into who we are, oftentimes who we become, what has happened to us, how it impacts us, and it could be both good and bad. So in our organization, we work with women before, during, and after childbirth, in all aspects, but truly in that postpartum period, understanding that mental health conditions don't just pop up overnight. The postpartum depression is brought on by pregnancy, but what about if that person had bipolar disorder? What if that person had any other type of mental health condition that is oftentimes merged with, oh, it's because she had a baby. But those are two different subsets of things that have to be addressed. And oftentimes, when combined, you're missing all the things. If you're only focused on the fact that she has postpartum depression and you already told her to go off her medicine, then you're no longer treating the bipolar, right? Or the schizophrenia, whatever it is. Those two things now have to coincide, untreated and treated, right? But keeping in mind at all times, when we think about healthcare, even when you can afford it, doesn't mean that that lends to you having a great experience.
Yes.
This thing within healthcare, oftentimes to me, I feel like it has no discrimination in certain subsets. Because even when I had a position in corporate and made over $150,000 a year, that did not stop my daughter from being born still. It did not stop my racism experience within that 2 weeks of being in the hospital. It didn't stop anything, yet the questions were always asked, do you have health care coverage? Where's your partner? When my husband was sitting right there. So all of these things that we will discuss in storytelling, I think it's important for us to just not always assume that one is getting care, assume that they have access, when in reality, those of us who look the part don't have it at all. I know people who dress up to go to the hospital just so they can at least get some type of decency interaction, first and foremost, to, you know, it's all, I always tell people, it's the person who answers the phone, that's the first interaction. And then when you get there and so on, it's like a chain reaction. So keeping in mind in healthcare, to me, everybody should be having these conversations together. Everybody, the janitor, everybody, the people you don't think, because those are typically the folks we're going to pass in the hallway. We're going to have an interaction with everybody within the healthcare system in itself, but oftentimes we limit that interaction to only this person, especially around mental health. It's already taboo. It's already stigmatized. It comes with so many apprehensions before you even have a conversation. So if you're pre-told someone is struggling mentally, you automatically think you're scared or they're gonna do something and you haven't even had a conversation with them. So when things like this come into play, the stigma across the board of healthcare, I think we're gonna constantly be dismantling all of that stigma. Like I said, we had a conversation earlier around, I don't feel like we can just eradicate stigma, but we can certainly reduce it by having conversations and showing them the opposite of maybe what they've been told, the opposite of what we've been seeing examples of. Just it's exactly what you've been saying. He said healthcare one way, you see it another way. All important though, right? Because maybe someone in the audience didn't see it that way and now they heard you talk about it. And so that continuum, I think, is like what we have to do when we talk about it. It's what MLK has always been about. Like you said, he pushed people. Like you said, he pushed people. He challenged people. And then he was like, what's next? Not I just push you and then you just fall, then you get back up and you go to the same behavior. I push you and then I challenge you to do better, to do different, because now you know better. I think once we hear something and new information, it is our responsibility to do better than we were before we heard that information.
Oh, that's so good. It's our responsibility to do better once we know,
Yep.
right? Do you have anything to add, Dr. Nuila?
Well, I mean, I think that what you said about the experience of healthcare, medical care, I think about that a lot, and I think that that's one of the saddest things to me is that you're right. People all across the country have terrible experiences. It doesn't discriminate, you know, and that should just clue us in that this is not working. And why is it not working? And I think that one of the real big reasons that it's not working is because it's just incentive driven toward profit. And that's what's going to happen, that people are going to have bad experiences because invariably people will be treated as, you know, potentials for profit. Their bodies will be, people will be thought of as like what type of profit they can bring about, rather than like focusing on the experience. What I appreciate is that if you remove some of that incentive, then you can give it to the person and say, okay, you know, can you try to make this person's experience good? That's what I agree with you that there are so many, like you can't make blanket statements. It's not like you have like a system and everybody's operating in that well. But I have to say, I do like working with my colleagues because I feel like that they are thoughtful of like the experiences that people are having in their hospital bed, in their lives. When they go home, we think about, well, what is the home environment going to look like? One of the programs that I work with right now, called Hospital at Home at Harris Health, for some patients who don't need to necessarily stay at home but can receive the care at the hospital in their own home, the nurses and the doctors come out to you. And that is so humanizing, to walk into somebody's home. I mean, for both parties, because then you're also welcomed into somebody's home. It feels like so wonderful to be welcomed to somebody's home. And you can see that the experience is in the spotlight there. So I really, you know, I think that that's right on what you said about the experience. And I think we need to focus on that experience, the experience of people. We think of healthcare as so functional, like you come in sick, we need to cure you. But I think what if we thought of it as like, this is also like an experience. This is also this is more than just like functionality. This is a relationship.
It's a relationship. I am thinking about the stories that you all shared in answering my first question, and thinking a lot about how policy creates illness and who we as a society believe is meant to suffer. We think about illness as something that is personal, something that is even accidental, but policy shapes health in very real ways. Housing, incarceration, immigration enforcement, and access to public benefits all play a role. I'd like for each of you to think through which policies are actively harming people's health, and who bears the brunt of those decisions. Would you like to start?
Well, I think what I mentioned, I think that we have a very vague law that says that you can avoid taxes and be a healthcare entity and and just demonstrate some community benefit, and that's supposed to be like this. This was formulated in the 1940s. You know, this thought that like we have the like nonprofit hospitals give charity care to people. Even the word charity, you know, like gets at me there, because I just believe that there should be a standard. There should be a standard that everybody should be able to access, you know, and it doesn't matter if you pay or not. And so that is one policy that I like. First of all, like if we could figure out that baseline, of course, but if but definitely I think that nonprofit hospitals have to do their part because they have been able to capitalize on that, on the vague nature of that law, the vague wording of that law, and not provide care for people who really need it.
Yes. I know you have lots to say to answer this question, Krish, because I know that you study policy so deeply and deal with it every day in your work.
Yeah, I was thinking about which one to highlight, and the thing that's most on top of our minds now, and it's a really important conversation that's happening in sort of niche circles when it comes to pre-trial detention, which is the county jail system, and mental health care. And maybe folks know this, but over 76% of our county jail system is pre-trial, which means legally innocent. They haven't been found guilty. They haven't even gone to court yet. And like I said, it's the largest warehouse of people with serious mental illness. So how did we get here? It didn't happen overnight. There were very specific policy choices that were made in order for us to get to this point where everybody now just shrugs and admits that the county jail system is the largest warehouse of people with serious mental illness. Now, if you talk to our sheriff, he'll say, I'm the largest provider of mental health care, but I will not call the system a provider. It is a warehouse. So what's happening is that people are trying to access care in the community, appropriate and timely care, which they don't get. And they end up being criminalized for their mental illness. So our state hospital is supposed to be our public safety net, our state psychiatric hospital system. Used to be you could walk in the front door if you were in crisis. About 8 to 10 years ago, somebody somewhere made a policy choice that we were not going to quite do that anymore. We were going to follow a utilization management system. And so, and there was some sort of memo, I guess, that went out to law enforcement. We don't know because we just hear this from law enforcement saying, well, we can't take them to the hospital anymore. So then what happens is that the person cycles through short-term emergency detentions, there's hospitals in the community and the jail, and then they keep cycling, which is what happened with Christopher. Christopher needed a higher level of care, but he never got that. He could never access that level of care. So we're waiting for a crime to happen, and God forbid, a victim to be created before that person goes into jail, and now that person is found incompetent to stand trial. And once they're found incompetent to stand trial, they have to wait on this wait list. It's called the forensic wait list to go to the state hospital for their competency to be restored. And when you hear our leaders talk about competency restoration, you have to be really careful because, and I've heard our sheriff say this, that we have the best mental health care program in our jail. Absolutely not true. What we have is a jail-based competency restoration program because the wait list for people to go to the state hospital was over 2-3 years long. So people were waiting in jail for years and years and years, just waiting in limbo to go to get competency restored. And you would think competency restoration is mental health care. It's not. We will restore you, stabilize you to some degree with medication, and we'll show you Law and Order episodes, and we'll tell you who a judge is and what your charges are, just so you can come back to jail and we can punish you for your disability. That's really what's happening with competency restoration. So a reasonable person would think, let's think about why are we in this mess? How can we deflect and divert people from the front end? How can we work upstream? How can we prevent this population from ending up in jail? Instead, our leadership in Austin has decided in Health and Human Services that we are going to push jail-based competency restoration because we don't want people to be sitting in jail 2-3 years waiting to go to competency restoration. So we've decided that the least therapeutic environment, which is a jail, is where we're going to pretend to offer you mental health care under competency restoration, right? So this is the conversation that's going on now in the state. And if you're not careful, this is going to get codified because this is being equated to mental health care. So this is the biggest policy fight that's going to happen this year in the interim and next year in the legislative session. And I might also, since we're all talking about healthcare, Health and Human Services is under sunset review. So every state agency has to go through sunset review every 7 years. This is when they go under a microscope. We check, if you really need them, what kind of policies we need to change. And Health and Human Services is your second largest bucket of funding. Taxpayer dollars, right? This is our second largest expense in the state. And so we all need to get involved. We all need to call our reps and state senators and make sure that we get the kind of recommendations that we need to make sure that this population stays out of jail, that they get community-based mental health care, that we build a continuum of care that is dignified, that invites people into care instead of repeatedly criminalizing them over and over again.
Well, thank you for that call to action too, Krish, and explaining that so well, where we are lacking in policy and what we need to push for community access. Kay, do you have anything to add?
I have so much. We would be up here all night. But Krish mentioned the sunsetting, what happens in Texas with certain things. And right now on the policy realm, our mortality morbidity review committee is up for sunset. And that is the committee that reviews the deaths in the postpartum period, 365 days. Thing is, there's never really been any funding for that. And so when we look at that, you'd think they want to keep something that they're not really technically funding a lot, right? No, but they want to let it go. They've changed it in so many different ways. Policy like that also has me torn, right? So I'm a policy person. I also do federal policy. But I'm gonna keep it local because federal is something completely different. But with the sunsetting across all spectrums of the option to sunset, our mortality morbidity review committee will just simply lend to more women's deaths within hospitals not being counted, not being explained for what has happened, why, and what are the solutions. So to understand that there's a chance that a committee that we had to fight to get reinstated is now falling under the sunset, that is the call to action. It is to call and say, no, we need this. Because here's the thing, remembering none of us are exempt. This could be our cousin, our sister, our friends, our coworkers that are at risk. And if we don't know what is happening, if we're not tracking what is happening, we'll continue to be in the know, and our mortality and morbidity numbers will continue to increase. Unfortunately, right now, a successful birth in Texas is day 366. You have to make it out of the 365-day realm to be counted as successful. Most of the mental health cases for us happen in the postpartum period. But if no one's tracking and counting that as a contributor, then how will we continue to know that that is true? How do we continue to know if the work we're doing is even having a small impact, right? We have such backup on our data. That's another thing. We dare not lose this again, to have more data that needs to be gone through. So it's these things that we can do. You know how sometimes you ask yourself, what am I supposed to do? A lot. Simply, honestly, a phone call, an email, something that, we live in a ChatGPT era right now. I don't think any of us have excuses. We can definitely do something. I know for me, I'm gonna state my claim before we even get to the next question of, I hope that you all leave out of this room and do something. It's something that you hear on this stage tonight that prompts you to do what you can do. But there's something that we all could do, especially when it comes to policy. We don't have to sit on our hands, because guess what? We vote all these people in. Nobody just sits them in. We vote them in. And we have the ability to save things within healthcare that are actually in our power. And to know what is happening within our healthcare systems, with our women, with our babies, with our families, that's what's at risk in so many different ways. And I'll just pause there.
Thank you for that. Okay. I want to talk about social determinants of health. we know that by the time someone reaches a hospital, so much has happened. Health is shaped long before that moment. We know by wages, by ability to afford housing, environmental exposure, racism, and other kinds of violence, right? How should that reality, change how we think about prevention, responsibility, and care? Would you like to begin? You're thinking through that question?
I'll definitely start with
Come on,
having
Kay.
trauma-informed care.
Yes.
If we skip over what is underlying, then how will we ever solve the issue itself? So when we talk about social determinants of health, I mean, we've coined that as SDOH, all the things that sound great, y'all, but it's so much more to it. As a social support provider, there's so much to it. Working in mental health, I want everybody in a support group. I want to get you the therapist. I want to get you all the things, right? But you could really honestly care less if you don't have nowhere to stay. You could. And that's just the honest truth of how we should be approaching social determinants of health from the individual that is standing in front of us and it is presenting in front of us, and not the one-size-fits-all approach. But that only comes from the understanding of address my trauma, good and bad, because there's good trauma. It's the thing that keeps you saying, I'm gonna keep trying, until you don't even know that you gotta stop trying. And that there's something else on the other side of that. So to me, addressing the real big picture of social determinants of health is having that trauma-informed approach to addressing who is presenting in front of you. I know for sure what works for the person before, after, and in between is not gonna work for that one individual person. You have to do it that way, and we oftentimes miss that. I always like to break things down into regular terms. You know how somebody says good morning, and someone says morning, and they're like, oh, what's wrong with them? They're not having a good morning. I mean, they're trying to tell you, but you want to keep pushing the issue. Are you okay? Is everything all right? Did I do something? I'm simply not having a good morning. Like, I can just say morning, right? But we want a response that makes us feel comfortable. Not the response that if I say good morning and you just say, well, actually, it's not a good morning for me. This morning when I walked out, my car didn't start. And you're like, I'm just trying to get my coffee, relax. I don't need to hear all that. But we have to be careful of how we engage with people because you never know, right? And so when we talk about social determinants of health, we can't assume that one doesn't have access to this, don't want to do this, don't want to do that. Circumstances, experiences, all of those things are shaped, and to me, that's trauma-informed care. When we're talking about social determinants of health, and trauma-informed care is not something, it's something that we leave out of that equation. It explains a lot of those things that we have put into the bucket of social determinants of health, but we only scratch the surface. We don't go deeper than the surface.
And what you're saying, especially in that last moment, is like this idea of the good patient, right? Like who actually deserves care and support. And when you are, you understand this, working in a system where many of your patients are struggling with poverty or struggling with housing or struggling with, so many things that in many systems, those people are not considered good patients, and they suffer as a result of that. Did you have anything to add?
Well, I just think we take the lesson from Dr. King, focus on health, and what that really means is what are the real components of somebody's health. And I think, there have been studies and there have been thinkers in medicine who have tried to think, what is it like the components of what helps you think about the outcomes of health. And in those studies it shows that the medical care that you receive is only 15% of how the effect of the outcome. It's other things you're where you live.
Yes.
It's not as much about the genetics. It's about the community that you live in, your access to good foods, to parks, to exercise.
Clean air.
And I think that's what we need to take seriously. We need to take that very seriously and think about what are all those other components. Can we get people good transportation? You know, can we instead of like, you know, throwing more concrete on the ground, can we find like real, like sustainable, good ways options for people to move? Can we get them? Can we link people to more parks and things like that? You know, and I think that's what I hear when I hear Dr. King say that is that people need to have, you know, access to all of those fruits of society.
Yeah.
There are no good patients. Yeah, there are no good patients in a jail, right? I mean, I was laughing because when you talked about social determinants of health, I'd never expected to hear that from a sheriff. And today, I will not name the county, it's in North Texas, but we were asking the sheriff to explain why they had over 66 custody deaths in less than 7 years. And their response was, well, you know, it's not my fault. People come in so sick into my jail because they're unhoused, they haven't had health care, they have been, you know, self-medicating, they're drug users, and so it's not my fault that people are coming in so sick and that they're dying. And if you look at the rate of death, it's about 10 per year. That's not too bad. That was their response. But if you really look at the deaths, if you break it down, a large majority of them were suicides. And then the other big chunk was quote unquote natural, which is where all your deaths, like they didn't get their insulin, so they died. They had severe schizophrenia and stopped eating and starved to death. That's a natural death. We took away their insulin pump because that's not allowed in a jail. And then we didn't replace it with insulin, so then that's also a natural death. So that's become an excuse. This thing about social determinants of health has become an excuse for sheriffs to say that it's not our fault that people are dying in our custody because they're coming in so sick. And guess what? Actually, when they come into our jail, this is one of the first times they actually have access to health care. And so they should be grateful because they have access to health care in the jail, which I don't even know how to begin to respond to that, because if the first time you were able to access health care is in a jail, that's a complete failure of your healthcare system.
Yes.
There are no non-compliant patients, there are only non-compliant doctors. I'm sorry, that's all I keep thinking about Paul Farmer saying, that there are no non-compliant patients, there's only non-compliant doctors. Yeah. Because the same system in a cage behaves differently, the same healthcare system. It comes with its biases and bigotry and, you know, the racism, all of that. I mean, when Kay was talking about her experience, I could not stop thinking about this, this young pregnant woman that I was talking to who called me from a jail, completely, you know, in panic. And one of the experiences she talked about was having been taken to the OBGYN from the jail. And she said, you know, it was the same OBGYN that I saw before I was arrested. But this time, because I was in an orange jumpsuit, she didn't even show me my sonogram. She didn't even look at me. I was not even a human being anymore. All my paperwork was given to the guard. I was not even shown my sonogram. That was her experience. With the same doctor, with the same healthcare provider, but this time she was in an orange jumpsuit. And so every time we have a miscarriage or a stillbirth or, you know, some horrific story of a baby dying in a jail, the response is very quick. Well, it's her fault. Because she should not have been in jail in the first place. It's her fault that she was there. So there are absolutely no good patients when it comes to jails.
Trying to use personal accountability as an excuse for systemic failures.
Exactly. Yes.
Yeah. Yes. Yeah. I'd like to talk about something positive. All of this is heavy and exhausting and very real, and so we can't deny it and not talk about it. But I also would love to talk about community. We're talking about Dr. King and the beloved community. You brought up community being such a huge factor in people's health. We also know that many communities have built ways to care for people outside of traditional institutions. You know, I always think of one of the major reasons that the Black Panther Party was infiltrated was because they were providing care and support for community. What community-based models have you seen that actually work, or maybe some that you have imagined that might actually work? And what do they teach us about care and what care can look like? Would you like to begin?
Sure. What my experiences with community-based models really goes back to before I was in medicine here in the United States. I worked in New Delhi for an HIV/AIDS organization and drug rehabilitation center, and it was inspiring, and it was a community organization that is just really about leadership. Leadership mattered immensely for that to work, and the reason that organization in New Delhi got into HIV/AIDS in the first place, this was in the early 2000s, was because they really wanted to do drug rehabilitation for people from this part of India called the state of Manipur, which is like very much to the east, where there was a lot of heroin at the time. And so HIV became prominent because of the sharing of needles as a drug problem. But that flexibility of mind that the director showed, like, it wasn't like we're only doing this. It was like we're helping these people. Do you know what I mean? It was like I was young, and I was very inspired by a director of this organization who could have that flexible mindedness of being like, this is about people. It's not about like themes or topics. We're not just drug rehabilitation. If we need to do this, then we'll do this to help these people. And I think that that's really something that you see in great organizations, that the leadership has that flexible mindedness.
Speaking of leadership and community models, Kay, I'd like you to talk about Shades of Blue Project. I mean, this is what we're talking about, community care and support.
So yes, lived experience. I will always say that this work, not job, this work chose me, because if it was a job, y'all, I'd have quit a long time ago. This is work. And I took my own experience of not knowing where to go and what to do and turned it into action. Only after getting the help and care that I needed, first and foremost, because what I don't believe in is operating from a place of hurt. And because I was hurt, I didn't want anyone else to hurt. Instead, I wanted to help people not have that experience. So we have a model of care that I actually travel worldwide, teaching doctors, nurses, community health leaders, moms, dads, family members. It's called the Inspire Method. And at the end of the day, it's learning compassion, because we don't know it. We think we do, but we have to allow our biases to be put to the side, and we all have them, even the best of us. And when it is called out and acknowledged and accepted, we do better. I've seen it. I've seen it happen in hospital systems across the U.S. Do better. Excited to do better because they realized that they weren't the greatest, and that it's not okay. Right? The thing is, once you acknowledge it and that you're willing to do better, you do better for the people that you serve. But what I also learned in this process is, because Josie said we're going to talk about joy, what I have learned is oftentimes our biases are a reflection of our own experiences. And when we don't get help, how dare we go and help somebody else, right? And that's what we have to shift. We're deflecting our own experiences of not getting or not being able, or automatically judging, right? So having people to pause for themselves and realize that maybe you are not getting what you need for yourself first and foremost, and it is reflective in your care. It's like the aha moment that our trainings, when they walk in, they think we're about to do a bunch of PowerPoint work and stuff. No, we're actually about to work on ourselves. Because we are the problem. We are part of the problem. And working within is my key point for us to realize that we can do better, we possess the skills to do better, but we gotta get something for ourselves. And so that's what we've been doing. That is our model of care across the board. I wouldn't do it any other way because there's never a day that I forget my hospital experience. There's a day that doesn't go by that I realize the only thing that I own in this space is my story and what happened to me. And so it is a constant reminder for me in this work to never do it that way, but to do it better.
Yeah. Thank you, Kay, and thank you for all of the work that you do. Krish, do you have an example?
I was looking at the time, so
Yes.
I was wondering if you... Oh, we got time, okay. So the question was, have I seen a community-based model? Not really. No, not in our work. No. I will say, though, that in building community with directly impacted families and their loved ones, we have been told by them that because we listen with radical empathy, that's the closest that they have come to a sense of healing and justice. And then they want to pass that on to the other members who are joining our movement, our movement building work. And so a public health worker recently said to us that, you know what y'all do? It's the accompaniment care model. Have you ever heard about that? And I said, no, I don't know what that is. I said, well, that's Paul Farmer's accompaniment care model is what you're actually practicing when you're really listening with radical empathy and then bringing people together with those stories and activating them and informing them to change policy. But it starts with listening deeply. And so people who come to us for our services never quite leave. They become advocates in their own communities. And so this community worker model, this peer support, I guess that's where I'm going with this, is peer support is what needs to happen more and more. And that's the model that we want to see built, but we haven't really actually seen a good model of that in our work. Yeah. Because there isn't enough funding.
Though. You have to acknowledge that you are the model. It's
Oh,
okay to say you're the model. When
Yeah.
you're the person that's speaking about it, I think oftentimes we skip over the work that we are actually doing, but you are the model that she is asking about. It's okay.
Thank you for saying that. You're right. It is easy to oversee
And
themselves.
sometimes you feel like you're in the visioning stage, but
Yes.
as you are visioning, you are doing. Krish,
Yes,
so,
yes, you're practicing. Yes. I guess we tend to skip over that because we look for external validation, and unfortunately, in this work, the external validation comes from funding, and so it's frustrating for public health funders to not see mass incarceration as a public health issue. And I think that's where it's frustrating to have this conversation about a community model, because it's like, why are you all not funding mass incarceration issues? Why is public health working in the silo and not even acknowledging that this is the biggest public health problem of our times, is mass incarceration? And so I think that's where this comes from. It's like, we're doing something. We don't know if this is a model.
It's a model.
Yeah, but yeah.
It's a community model. That's what community models are.
you.
It's a community-centered model. We have to shift the language. Sorry, I can't sit here and not say that.
Yes.
As community organizers, we have to shift the narrative, or no one else would do it for us. And so we obviously don't fit into what has been deemed the model. So you have created a community-centered model. I want you to start using that as we go forward. A community-centered model. It's gonna help me out because I say it all the time. Community-centered model is what it is.
Yes. Yes. And now we're moving on to a few questions from the audience. And this first question from Maya Sleteso, I hope I'm saying that correctly, actually matches the last question that I had for the panel, which is around what community action looks like. The title of this talk, this conversation, is We Got Us, right? I find often when I am working with folks around advocacy and capacity building, a lot of people just don't know how to show up and what they can do as community members. People don't think of themselves as activists or organizers, or they know that they aren't a medical professional. What can regular everyday folk do to help and support this movement of human rights and care, and improving the health of those who are most impacted by so many systems and so much harm? Do you have an example?
I will say in our work, when we get that question, and if you're not a directly impacted person or a loved one of a directly impacted person, then what we ask is, come and bear witness. When our moms and our brothers and sisters and husbands of people who are locked up and directly impacted, when they are advocating for their loved ones at, let's say, the state oversight agency public meeting, or in commissioner's court, or all these different spaces where we bring them for public comment and testimonies, it's exhausting and it's intimidating and it's a tough experience. And so if you have the capacity to help, come and bear witness. Sit with them, hold their hand, listen to their story. And that sometimes is the biggest action, most significant action that you can take for this community in our work. So if you all have capacity, feel free to reach out and we'll connect you with somebody who needs that support.
That's great. And Maya gave the example of ACT UP. I wanted to pause and talk about ACT UP, and I don't know if you all are familiar with the work of ACT UP, but this was just regular, everyday folk who saw people in their community suffering and dying. This was at the height of the AIDS epidemic, when no one wanted to be involved with those who were living with and dying from what we called AIDS at that time. So I think that is also a great example. Do you have some ideas of what everyday folk can do?
Awareness is key. So it's really like sharing information and not holding it like you learned something today. We have a hashtag called The Conversation Continues. So my goal is for y'all to leave out of this room and keep the conversations going. Sharing, talking about things, and then volunteering. And if you have connected resources, sharing those resources when it's all said and done, especially if you know like, oh, this won't help me. I always often say that I'm not in every room for myself. I may be in the room for somebody else, and I'm supposed to be listening and retaining this information and taking it back to them. So that's the biggest thing around for me, awareness and sharing information, and then also volunteering where your passion lies. And it's ever changing, right? Some people volunteer in multiple places, but it's really, that's how you truly make impact, is volunteering and sharing and spreading the message.
And I like that idea of volunteering, and we were talking earlier about the importance of collaboration and coalition building, particularly in this moment. I think that is also something to consider. It's like, think about what your gift is. Think about who is doing the work to make the changes you want to see in the world, and simply connect with those people to offer your gift, whatever that is.
Yep, that's it. The simple things.
Yeah.
My thoughts go back to the introduction and Dr. King and his thoughts about morality and this, just acknowledging how difficult it is to live in a capitalistic society where there is so much temptation, where there is so much like push again, like away from morality, where you do have to sometimes put the brakes on yourself and say, what does an action that is not directed toward me but toward others look like? And I mean, sometimes that's just very introspective per person, for people. Sometimes that is born out of just, you're not sure. You just go out and try a new activity and you find something. But to me, I think that is really one of like the seeds for how you generate community. the question of like everyday, I feel like we're all everyday folk in some ways, you know what I mean? So it's like there's nobody there that's just like that is just like purely like has no connection to anybody, right? I think that everybody has the potential to connect, and you just have to kind of think to yourself like, where is my life so individualistic where I can carve out a part of it for something bigger than buying, than, you know, consuming. That's really, really hard. That's really hard in our society. But I think that is, I think that you know, that's what when I hear, you know, Dr. King speak, that's what I kind of like hear also, is just like that we need to live lives for bigger purposes rather than for, you know, buying things.
Do we have time for one more question? One more? Dr. Angela Davis says that freedom is a constant struggle. This community member, our audience member, is asking, can you speak to the crucial role that abolition plays in our work to create a healthier society? And when we're talking about abolition, we're talking about the dismantling of systems, but also, which is rarely spoken about when we talk about abolition, it's like building something new that centers care and community and the human experience, right? Do you have something you'd like to share?
I was just reflecting on the first time somebody called me an abolitionist, and I had not thought about myself as an abolitionist, and they said, well, it says here in your vision statement that you want to replace punitive systems with communities of care. Well, that's abolition. And I had not quite connected that 20 years ago when I was first sucked into this work, and it's not a job, it's a, like Kay said, it's a calling.
Mission.
My friend went to jail, and so I was sort of stuck doing this now. And she went to jail for it was an environmental health and justice action because her bay, she's a fisherwoman, the bay had been poisoned by the chemical company, so she went to jail protesting, and so that's why we have Texas Jail Project today, is because she went to jail for 5 months for the right to clean water and air. Yeah, I'm just sort of, if we invested in all the things that actually make us safe, which is clean water, air, housing, community-based care, mental health care, economic opportunities, parks, libraries. I remember when we first moved to this country 25 years ago, the libraries were open like all the time, Sundays, 10 p.m. at night. I would sit in the libraries because I couldn't go to school, I couldn't work. We had just transferred from India because my husband was transferred in his job. And I would sit at the libraries all day long and volunteer, even on Sundays. And now we don't have libraries that stay open that long. They're like limited hours. And so I think about all the things that we need as a community to keep us safe, which would prevent the criminalization. Because right now, who is sitting in our jails? People who are sitting in our jails are people who have been criminalized for their mental illness, who have been criminalized for being poor, because we are one of only 2 countries in the world where we have cash bail. So it's not, we haven't locked you up because we think you're unsafe, we've locked you up because you can't afford to buy your freedom, can't bond yourself out. It serves no public safety purpose to have a cash bail system, but that's what we have. And then we've criminalized reproductive rights and, free speech and pretty much everything else you can think of. And so if we really invested in the things that we need as a community to keep us safe, we would really not need jails and prisons for the most part.
Yeah.
Right, and so that's how I see abolition.
Yeah. I think that one crucial thing that we should think about when we're talking about abolition and how it can help us form a healthier, much more just society is to remember that we're living abolition now, and that much of the work that we're talking about today is abolition work. I think that we often look at abolition as something that is impossible, right? We cannot live outside of these systems. But when we talk about community action and community care and standing in the gaps when systems fail us, that in itself is abolition work. And I think that if more of us recognize that, then we would have less fear around words like abolition, you know?
I just want to say agreed. It's how we look at things. Shifting our mindset is one of the biggest key components of that. Because if we make a plan to burn it down, we have to make a plan to rebuild it. And if we're going to dismantle systems, then we have to look at what are we actually extracting.
Yes.
And what are we rebuilding? What parts are we keeping? Because there are some parts of the system that work. It's the part of the system that don't work that we want to extract, right? But again, if we make a plan to burn it down, you got to make a plan to rebuild it.
Yes.
It's not one without the other.
And they're working simultaneously.
Correct. I think that's our hardest challenge. I just won't say that like it's easy breezy. The collective, collaborative effort comes with its stigmas. It comes with its own bias. That if I do more than you or you do more than me, you're gonna get more than me. I'm gonna get more than you. All those different things. So understanding the power of collaboration and how we definitely, and this is one of the biggest, truest statements. We do go further together.
Yes.
But we also have to understand what that looks like and what that feels like and what are the outcomes of that.
Yeah. I think that we're wrapping up, but before we do you have something to add?
I think we should end it like that. I
Yeah.
think that was well said.
It's
So
a
thank you
perfect
all.
ending.
Thank you so much. Let's give them one more round of applause, gratitude for their wisdom. And I want to thank all of you for coming out tonight. I know we're still easing into 2026. A lot has already happened, so you have choices of where to be, and I really thank you for being here together. And I just want to echo everything that they're saying. We each have a role to play, and it's up to us. We have the responsibility and the sacred path to be able to find that out and then to live into that role. So there's no shortage of opportunity. So just take some time, if you haven't already figured it out, to try some things out, as they said, and find your role. We need everybody. We need all of us. I do want to make just a quick plug to follow the Rothko Chapel on social media so you can see all of the great other conversations like this that we have planned for the year, including I want to announce that we're going to be hosting our 2026 Oscar Romero Awards ceremony on Saturday, April 11th. We'll be honoring other amazing grassroots activists, artists, and faith leaders doing work related to health justice across the state of Texas. We want to have everybody here to help celebrate those folks. And now I want to just invite us to go out to the plaza, stop by one of the tables of our community organizations, learn what they're up to, and join us across the street for a reception and book signing of this amazing book, which tells more of Dr. Nuila's story and other patients in Houston. Thank you so much for being here, and we'll see you outside.